Welcome everybody to our WOT online session on bladder and bowel. Before we begin, I'd just like to acknowledge the traditional custodians of the land that we live and work on, the Wurundjeri people. I'd like to pay my respects to these people, their culture and their traditions. I pay particular respect to their elders, past, present and emerging, and any Aboriginal and Torres Strait Islander people who are in today. That's all I need to say. I'll hand over to Naz Erdem, who'll do the introductions. We're going to begin our session with bladder. We're going to have a poll at about halfway and then have finish the session off around bowel management. So enjoy.
Thanks, Sal. So just want to introduce myself. I'm Naz from AQA Victoria. I've got a spinal cord injury, C6 complete. I've been in a wheelchair for about 30 years now, so it's been a long time. And today we're going to concentrate on two topics, one bladder and bowel. And the idea is to go for about an hour, roughly, on each topic. And I'll go around the screen. We've got a lot of people here with lived experience, people who've trialled, different types of bladder and bowel management. And we've got two specialists from the Austin Hospital, Anna Brown and Kath as well. So I might start off with Jeff, just to quickly introduce yourself, Jeff, and we'll move on to the other guys as well.
Hi there, I'm Jeff. I'm a C45 quad and been in had a spinal cord injury since 2001 and been originally in New Zealand, where I had my accident where I was running my business, and then I moved back to Melbourne where I grew up in late 2007, and I've been living out in the eastern suburbs, Camberwell or Glen Iris, for the last, since then.
Good, thanks, Jeff. Peter's also works at AQA Victoria, and he's got a lot of experience with both bladder and bowel. Do you want to do a quick intro, Peter?
Yeah, I have lots of experience with bladder and bowels every second day, bladders and bowels. But I'm a C45 quadriplegic, and I'm supported by carers at home with my wife and son. So I've been living in the community and spinal cord injury for 20 years plus, a little bit longer. Work at AQA 3 days a week, and get out to do as many hobbies and things as possible, but of course not at the moment, but looking forward to that turning back on.
Good, thanks, Peter. And we'll move on to Mario.
Thanks, Naz. I'm completing the triple threat. I'm the same level as Jeff and Peter. And in fact, Peter's a better looking version of me. He was at the Talbot the year before me. So when I came in 2001, Peter left, and I didn't stop hearing all the nurses telling me how amazing Peter was. And yeah, that's usually my infection, not Peter's. But yeah, so at the time I had the accident, it was quite ironic because I was a medical registrar, surgical registrar at the Austin. I was actually working on the spinal ward, so I came back home literally when I had my accident. And life's been good to me since then. I've had, very good health, and I work as a medical practitioner and an educator, and I try to give back by doing things like this and volunteering with AQA.
Great, thanks, Mario. And Lynn, who also works for Austin Health, and she can tell you about herself a little bit more.
Hi, my name's Lynn. I'm a T12 para. I've been injured coming up 15 years, and for the last 10 I've worked as Austin Health as the spinal peer support worker on the Spinal Community Integration Service. Thanks, Naz.
Excellent, thanks, Lynn. And we'll move on to Josh, who also is a colleague of mine at AQA Victoria.
Yeah, I've been lucky to be a colleague of Nars and Peters, and also work with Lynn and Sal. I had my injury back in 2005 on Australia Day, become a C6, C7 incomplete quad. And yeah, I've been working with AQA for about 2 years, and yeah, that's pretty much my story.
Excellent, thanks, Josh. And we've got one of our mentors over here, Lenny. Just wanted to introduce Lenny there. As you can see, Lenny works out a lot as well. Had to throw that in.
Yeah, hi everyone. My name's Lenny. I'm coming up to 4 years in October being in the chair, so I'm a T4 complete para. I've been doing a little bit of peer support mentoring work with Spire, who initially mentored me in my early days, which has really helped me come good as I delved into addiction with ice for a couple of years. And yeah, it's been a tough and wonderful journey as I've nearly clean for 2 years now. Yeah, so it's been.
Thanks very much, Lenny. And we'll move on to Julie now. Julie's got some camera issues, but believe me,
The great chin.
she's
Still young.
yeah, she's been around for a little bit as well. Julie, do you want to just introduce yourself quickly as well?
Hi guys, I'm Julie. I'm C5-6 quad. Had my accident in '98, so yeah, I'm well. Been in chair a long time now. Yeah, just my kids. My daughter, when she was 16 months at the time of my accident, but she's all grown up now. So yeah, I've had lots of different experiences whilst being in the chair.
Excellent. Thanks very much, Julie. And move on to...
Naz, can I just interrupt? I forgot to mention the hands up option. If people can't type in their question or answer, there's an option to raise your hand. If you raise your hand, we'll be able to give you, put your sound on or turn your mic on for you so you can ask your question using your voice. Sorry to...
No, that's right. So anyone out there, if you've got any questions, please, don't hesitate and type your questions away, or like Sal said, put your hand up and we can sort of follow up with if you've got a question or not. So I'm just going to move on to Kath from Austin Health as well. Might get Kath to talk about her role and experience as well.
Thanks, Naz. I'm Kath Byrne. I'm currently the spinal urology clinical nurse consultant at Austin Health and within the Victorian Spinal Cord Service. So my role here, I work with the acute injuries coming in, and I see patients in rehab, and then I'm open to outpatients as a part of the VSES for any troubleshooting issues or problems that they're having. So I can be contacted all the time. Well, not all the time, but you're able to contact me. And I was lucky enough to work a bit with some of the AQA guys on a recent bladder project we did here at the Austin, Rob, around changing the practice. So, yeah, that's me.
Thanks, Kath. And last but not least, Anna Brown, which many of us probably know already.
I don't know whether that's a good thing or a bad thing, Naz. I just put my headphones in because I'm getting echo from Kath next door. So, okay. So, yeah, my name's Anna Brown, and I will know some of those names there. Some are not familiar to me, but I've worked in, my role is a clinical nurse consultant, and my role is to run the outpatient clinic for the Victorian Spinal Cord Service. So at the moment that role is a little bit sort of up in the air because we don't have face-to-face clinics, but we are running telehealth clinics and with the team. But the phone is always hot in my office. So yeah, so that's probably, and my role or my specialty, I suppose, is bowels. Or it's my plain name. Don't say it like that, Naz.
It's a nitty and gritty area that we all have to deal with, and it's not fun. But a lot of us would have had trouble along the way, which stops us from doing what we want to do. really important that we get our bladder and bowel routines right. Otherwise, we can't move on. You know, we can't really do the things that we really want to do. Just wanted to talk about myself now, and hopefully we can all do the same as well. When I hurt myself, I had an indwelling catheter. I've had a suprapubic catheter. I used to do IMCs as well while I was in the Royal Tablet. Sorry, not the Royal Tablet, but rehab. And for years now, I've moved on from all of that and I've been doing condom drainage for many years now. And it's something that works for me, but I'm glad I trialed all the other options as well. Again, I'm happy with condom drainage, but I still have issues with it. You know? But you learn to see what works the best for you and what other options you've got too. I mean, this session is really going to be interesting for me as well because I'm going to learn quite a lot too from the other guys. So, might move on to probably we'll start with Jeff and just get Jeff to talk about what his management is like now and what you've trialled along the way too, Jeff.
We're talking bladder here at the moment.
Bladder, that's right.
Okay. I was given a suprapubic catheter pretty early on after my accident. I'd say maybe a week after my accident, and haven't had anything other than that except for maybe about a month when the district nurse messed up with one of my catheter changes and it closed up, and I had to have a urethral catheter for a month until I could get in for another operation to reinsert the suprapubic. I used to have a lot of problems with catheters getting blocked and having to have emergency changes in the early days. And I was living in New Zealand, and the protocol over there was when you had an SPC that you flushed saline in and out of it every week. And when I moved to Australia, the district nurses said that they wouldn't do that, and it wasn't part of their protocol, and I was horrified. But since then, I've never had a blockage and never had to have an emergency change. So I think that was maybe a good thing to listen to the district nurses here. And I drink a lot of water, and I think that really helps, and means that my leg bag needs to be emptied more often than not. But yeah, I think I take cranberry tablets every day, and I don't know whether they've helped or not, but certainly haven't been a problem. I used to have my catheter changed every couple of weeks, but I've sort of stretched it out now. I have it changed every 4 weeks, and I don't really have too much trouble.
Okay.
Yeah.
No, I know a lot of us will probably talk about keeping our fluids up as well, and that's more than one reason. Might ask, might go into Peter and see how you've gone, Peter, along trying different management techniques.
Yep. So when I was going through rehab, I tried intermittent catheters, but of course I couldn't do it myself because I don't have the hand function, and it was just to see if I could get my bladder working by itself, filling up and releasing. So that was through the Austin and neurodynamics and checking all that out. And in the end, that didn't work for me. I tried that for about 6 months, and then I went to a suprapubic catheter, which suited my level of injury and my lifestyle much better, actually, because then I didn't have to have controlled fluids or do catheters at night and all that sort of thing. So it was a lot better for me to have a suprapubic catheter. I get my catheter changed by district nursing once a month because they do block up a little bit with me, but that once a month changeover seems to work really well for me, and I don't block up anymore. I also use medication to sort of lower the acidity in my my urine to stop bugs or UTIs. And so I take Hiprex and vitamin C and apple cider vinegar. But I mixed apple cider vinegar with water, of course, because I forgot to tell somebody that one day, and they drank the apple cider vinegar straight, and they weren't too impressed with me. Yeah, so add water with your apple cider vinegar. Yeah. So yeah, there's many different reasons and things that what most suits your lifestyle and your level of injury. That and really listening to the nurses, urodynamics, and keeping up with that on a yearly basis has been a big help for my bladder health. So I continue with that because, you know, there's pros and cons around that, and you always learn something.
Can I just say that I take the Hiprex and I take Hiprex and high dose vitamin C as well, probably prescribed by the same Dr. Joe as Pete.
Yeah, no, thanks, Jeff and Peter. And this is something, once we talk to some of the other guys, I'd like to ask a question from Kath, or to Kath, about prevention, you know, because it seems like different people are using different things for prevention, and that's a big area where I'm sure a lot of us guys get a lot of UTIs. I know I do, and people try different, I don't know, additives or medication to change the acidity in your urine, and yeah, but we'll see what other people do, and yeah, we'll ask Kath about her experience from other people. So Mario, if we go on to you, how's your management been going over the years?
I've had pretty much the same management from early days on. I had the intermittent catheters just initially because they were trying to build up my bladder volume. I don't think that's something that they do now, but well, anyway, so I left with a condom drainage, which I've had ever since. I've had no problems with it. I have very little penile function, so that suits me fine having a condom on all the time. And I don't get many, or haven't had urinary tract infections. Early on the piece, I had not really an infection, but I had a colony of E. coli growing in my bladder. But that's since cleaned up. And so now, I think what Jeff was saying, I think all of us in chairs drink a lot of water. Our sodiums are always low because we want to flush our catheters through. And that's a good thing to do. And I've sort of managed with that ever since, yeah.
So I might just go next, mate. And there's also, I might throw, there's a couple of questions here coming in. So I might throw it to Kathy, if I may. It's regarding a question from David. So about that bladder management, Nars, the question was, any comments on using Eurovaxin, if I pronounce it correctly, VAXON, on recurrent E. coli UTIs? Do you mind speaking to that briefly, please?
Yeah, I think there's a common theme already coming up amongst everyone, and as I look through more of the questions, we're talking about UTIs and trying to prevent UTIs. So UTIs are a pain. They really affect people's quality of life, and it's probably the #1 indicator for why people change management or what management they choose. So Eurovaxin is the type of, to be honest, I don't know a lot about it. Thanks, David Archibald, for sending me that question. But it's like an oral E. coli supplement or kind of therapy to my understanding is to help create a safety barrier in the bladder. We've done some trials here at the Austin with an E. coli numbered 83972, where we find that sometimes when we put the E. coli in the bladder, it protects the bladder wall from getting infected from other bugs. So a Pseudomonas or something that was making you really sick. So if someone was to figure out that the bug that was making them unwell is something other than E. coli, and yet they've got no more antibiotics left on that resistant or sensitive list that you usually get when you take a urine spec, and maybe where we look at trying something different. So Urovaxum is probably one of those ones that are trying to create an E. coli environment into the bladder to help prevent from other bugs. To be honest, I don't know many people on it that have used it. I don't think there's an issue with using it. I think you could give it a try. But in terms of Hiprex, vitamin C and all of those things, you've got to kind of work through what you're trying and what you're working, and maybe not try everything all at once.
Nice. Would you like me to speak on my journey now, Naz? Because it's pretty much like a Netflix film.
Yeah.
My bladder journey.
Hopefully we answered that question. But if you want to continue, Josh, about your different things that you've tried and how you think you're going now.
Yeah, because along the journey, because there's another question here from Pradeep, and it'll probably lead into part of my, I guess, what do you call it, bladder management journey. So as I said, I went through in 2005, and at first, for my spinal injury, I was able to hold liquid. And then I imagine, and the experts here can speak to it further, but I found after a couple of months that I started voiding. So I went to condom drainage. And then from there, like, I really wasn't good for me because I had high blood pressure and there was a bit of dysreflexia. And then from that, I tried some Botox down the track. And for me, and just I guess, full disclosure, this doesn't affect that many people. But for myself, I found it didn't work. And I also lost a lot of muscle strength. And I know of 2 others, but majority I know it works well for. And then from that not working, I then went to a bladder augmentation. And that's, I guess, a very, final step in the surgery of exhausting all options. So just to give some context, that was over 7 years I did my bladder journey. So what I ended up doing is definitely, I guess, a more extreme ends. So I might get you, Kathy, then to speak about the Botox and how that's being used.
Yeah, thanks, Josh. So Botox has probably been on the market now we've used it probably more so in the last 8 to 9 years. Before that, bladder augment surgery, the one that Josh is talking about, was actually more common than it is now. So Botox is kind of replacing that medication that helps to relax the bladder. I'm going to use my hands a lot. Relax the bladder. So when you find your bladder is really tight and small, and so there's a couple of reasons why people may have some incontinence or leak, and it may be because their bladder's overactive, so it's squeezing at the wrong times, or it may be that it's just its inability to stretch is gone. So the compliance of the bladder changes, and so depending on what that is, will be depending on the management. But when we get to the point of requiring Botox or suggesting Botox, it's something that's injected into the bladder wall, around about 200 units. A lot of the time we go to 300 units, and that's around about the max dose. It's done not everywhere, but here at the Austin, it's done under anaesthetic, and it's a rigid cystoscopy. There are some places that do it under local, so you can stay awake for it. And it's injected in multiple sites across the bladder wall, and that helps to essentially plump up the bladder like a empty face, and help it to relax. So the idea is once the bladder can relax, you can store more urine in it. When it comes to the time that it doesn't work, or people have side effects, so Josh is probably one of very, very, very few that we're seeing. So we do a lot of it. Like John Rogerson talks about the side effects of some muscle weakness that may have an effect, and it's 0.1% of the population that actually get it.
Lucky man.
Yeah. Woo. So I guess, so I would say a majority of people that I think have had it have found it very, very useful. You need to have antibiotics before your procedure. It's injecting a lot of sites into your bladder wall, so you want to make sure you're not going to get a nasty UTI after, which sometimes does happen, unfortunately. And so the main side effects of that, the side effects from the rigid cystoscopy or the anaesthetic, or the bladder augmentation, I can see it coming in now. What is a bladder augmentation? So bladder augmentation, or a cleanse procedure, is where they slice down the bladder and use a piece of your bowel and stitch it into the bladder to make it, they call it clams, to make it it looks like a clam with a stitch of with bowel in it. What that does is that it stops the sphere of the bladder, so it stops it from being this tight organ that can kind of be real.
Not sure if we've lost Kathy.
Overactive, and it just kind of allowed. So majority of people that have bladder augmentation are very, very. Are we there? Am I back?
You're back.
You're back.
You sort of froze a little bit, Kath. I'm not sure if everyone
Yeah,
got
you're in, Kath.
Yeah, this is Austin Health. It's right up there for internet at the moment. I'm not sure where I got up to before I froze.
You're speaking about the bladder augmentation and using your hands to describe the using your bowel.
Yeah, so basically putting the bowel in there allows you to store lots more urine essentially and stops that overactive contraction, so it stops that force of urine trying to come out. By all means, it's not a minor procedure. It's a pretty major operation, and Josh can probably attest to this.
Yeah.
It's not something we would jump into straight away. There are complications down the line, and there are things you've got to be careful of, but it's definitely one of our tools that we use. So if someone's got incontinence that's been going on for years and you're megally pissed off in both ways, you know, it's something you should talk to someone about, because it's there, it's an option, and while it may not be minor, we can try and have a crack at seeing whether it's useful for you.
I might just repeat, Nars, before you take back over. Yeah, to Kathy's point, it was 7 years until I decided to go down that route, and it's yeah, it's a serious operation, and you're knocked out for a couple of months and out of action. Thanks, Nars.
So you trialled different things over the years and didn't think they were like a good solution for you, and finally went to the augmentation afterwards.
Yeah, they didn't work for me, and even taking the ditropan, I was getting the cotton mouth. It just, with my hyperactive bladder, it just wasn't working. And then also I might throw back to Kath with the Botox. I found with a couple of people, what's the duration on that? How often do they have to get it?
Yeah. So I can guarantee you, if you've got a really overactive bladder to begin with, that you've been struggling to get in hand with either ditropan or something like that, the Botox will work, but it'll wear off quickly. That's what I see. So I see large doses. So if you also find you're someone who has lots of spasms and things like that, I can kind of almost align it, and we can pick it now, how your bladder is going to behave. If your legs are really, they tend to set each other off. So some people, it can last 3 or 4 months, and that's the kind of person that we would start to look at augmentation for, or if you obviously had some side effects from the Botox. But others, it can last up to 12 months. Most need it, again, 6 to 9 months. And also, then again, it depends also if you're having Botox when you've got a suprapubic catheter or whether you're doing intermittent catheters, so what you're doing the Botox for. So, but mostly 6 to 9 months would be around about the middle.
Excellent. Thanks very much. Just before we move on, just wanted to ask, Josh, you mentioned it affected your muscles. Did you mean the muscles in your bladder or
no? No, my body, mate. Like complete 6'6", I couldn't transfer. I lost a substantial amount of strength. But yeah, to Kathy's point, I haven't heard the cases that often, so I'm one of the lucky ones. So I don't want to scare anyone off, because this is a great, like Kathy mentioned, it's not permanent, where the augmentation is sort of the last resort. So it's definitely an option to explore where, it's not permanent and you can go down other avenues.
Excellent. I think, Lenny, did you put your hand up? You can ask a question.
So, not a question, but so I've had Botox. I've had three Botox 3 times now. The first time lasted probably about 7-8 months. The second time was about 4 months. And then the time after that, I had it in December last year, and I'm still going strong. So for me, I had a hyperactive bladder where I'd weigh myself quite frequently, a couple of times a day. So then obviously my intake of water, I dropped, and that's obviously not healthy. So then I started doing, either more catheters, which then brought on more UTIs. And then, luckily the Botox is, for me, it's been a wonder. It's brought that independence back, where I'm able to have a coffee and not weigh myself, or even have a beer and not weigh myself straight away. Where I've got the confidence within myself, I can, throughout my evenings, I still use a condom drainage at night time, because I can leak if I end up, because I do exercise heaps, and I do have a lot of water and a lot of fruit, so there's a lot of fluid in my body, so I can weigh myself. But in saying that as well, with the Botox, if I do have a long sleep, it actually causes me a lot of neuropathic pain because my bladder is expanding, and because I'm not releasing. It does cause heaps and heaps of pain for me. So throughout my nights now, I'm generally awake, like to do a catheter every 4 hours because the pain might be a little bit too much. Because once I go flat, obviously there's a lot of like I have a lot of fluid retention through my ankles, so I end up peeing a whole lot more at night time. But yeah, for me, Botox it's been great. It's been absolutely great.
Excellent, thanks, Lenny. Just wanted to move on to Lynn. Lynn, do you want to just talk to us about the different management techniques you've used over the years and what's worked and what hasn't?
Well, I've pretty much tried just about everything that everyone's talked about except for the suprapubic. So I do intermittent catheters. I definitely have the full bladder spasm and pain down my leg issue. Fairly early on, I started leaking, and so certainly have an overactive bladder. So started on the Ditropan, got Josh's cotton mouth, eventually changed to Vesicare, and that made that a lot better. But then that wasn't sufficient, moved on to Botox. Botox worked well for the first couple of rounds, and then that wasn't enough, so it was Botox and Vesicare. And it seems I might be have a great immune system, be finding that Botox off because I have quite a high level of Botox. And for it to be able to work now, it's Botox plus Vesicare plus Vetmega to be able to keep it still. I should have had my Botox in May, but of course due to lockdown that hasn't happened. Yeah, Kath's got it. I saw that face. So the Botox is worn, is in the process of wearing off, so I get both the spasm and the pain, but also the full-on leaking.
Nice.
Bring on lockdown.
So Naz, there's a question on Vesicare for Kath from Stephen.
Yes, Stephen's coming in from both sides. He's mentioned something in the chat. I think, Stephen, I can't totally remember the case, but I do remember you were having some issues with leaking, and he wasn't taking Vesicare that often. So we upped the dose of it and kind of got on top of that. And so I think with Stephen's case, sometimes UTIs can mimic with leaking to begin with, and sometimes you could you can manage a bit longer when your bladder's more relaxed. So if you've got an organism in your bladder that's irritating your bladder, sometimes if your bladder's relaxed, you may not have leaking or things like that. And a lot of people can flush out that UTI with a bit of water and things like that rather than needing antibiotics. So it's really good to make sure your bladder's in a really comfortable, healthy state to begin with, and then things don't tend to set it off like bladder and bowels, which I know is on the list as well somewhere. But yeah, for Stephen, we increased his Vesicare dose, and that seems to have worked to treat. Maybe I'll touch on the medications that everyone's talking about. So we've got Ditropan and Vesicare and Mirabegron, which is also known as Vetmega, and then so it's kind of like we go up this scale. So we start with Ditropan. It's cheap and nasty is what I call it. It doesn't cost much. It's very, very effective at what it does, but it relaxes those same receptors that are in your bladder the whole way around your body. So dry mouth, dry eyes, drying your bowels up. So they're all some of the side effects that you'll have with it. Some people really like it because it stops them sweating. So I know people that haven't needed to take it because they've got Botox, but kept a really low dose because they didn't like it because they sweat too much. So it has that effect. It dries everything out. It relaxes the bladder wall. So and then you move on to the Vesicare and Vetmega. They're more expensive type, and the receptors are more honed into where they work in the bladder, so there's less overall side effects. Vetmega is relatively new. In saying that, we've used it probably for the last 5 or 6 years, and it's been a bit of a game changer for people that it works well with. I don't believe it's as effective as the Ditropan, but for some people that just need to calm their bladder down a bit, it works a treat. That it It works directly on those receptors in your bladder. So there's no other side effects around your body in terms of drying out. And the only thing that it does, it can tend to do, you've got to just watch your blood pressure when you start taking it. So there are steps up that we try and go through with Botox. Sometimes we use them in combination, and like Lynn, sometimes we do Botox and we find that doesn't work as much or may not work as long, but you don't want to get it as frequently. So we come in and out with all the other medications to kind of mix together to see if we can get a good picture.
So, Kath, all of those medications, they were to relax the bladder, pretty much?
Yeah, we're all
That's
talking
right.
directly about trying to
Yeah.
control either that overactive bladder contraction that happens sometimes, or the inability for your bladder to stretch out. So it gets really, really stiff when it gets full. So all of those are trying to either relax it so it doesn't squeeze, or relax it so it can stall better.
If I may, Naz, Kathy's mentioned about the bladder, you know, having organisms and different things that make it irritant and make you, I guess, void more often. What are some of the things you try to tell the people out there to best manage it and keep those UTIs away? Whether that be, I've heard of low antibiotic doses. I'm not sure if that's still common now, or we've heard of cranberry tablets, vitamin C and the like.
Can we just want to hear from the other guys quickly, because
Sorry, Naz.
no, you're right, because that's going to be a pretty topic, and I think we'll get like we'll spend quite a bit of time talking about prevention and also how people manage infections. So we'll come back to that if that's okay. Lenny, did you have a question?
I was just going to talk about that. I just wanted to know what that VisiCare was, but Kath explained it. Yeah, cool. Thank you.
Okay, no worries. Just wanted to go on to Julie. We haven't forgotten about you, Julie. So if you want to just talk about your different management options over the years and what's worked and what hasn't worked for you.
I had a suprapubic catheter put in when I was on the spinal ward, and I haven't had any problems with it. I've had blockages a few times, but I just make sure that I keep up my water and my fluid, and I'm pretty right with it. Like, I've had to change the different types of catheter that I've used because they've started to irritate the bladder. And I know probably the last 12 months, 18 months, I've started using Ditropan. But overall, yeah, I've just stuck with the suprapubic, and yeah, I've been really lucky. Haven't had many problems with it at all. Yeah.
So that's pretty much, you're pretty happy with that, and you haven't had the need to trial different options.
No.
No, excellent.
No.
Good. Did anyone else there have anything more to add to that discussion?
Have we been answering all the questions that people have been asking, or because
I think we're monitoring. Yeah, hopefully we won't miss any. But we'll stay on top of that.
There's a few questions coming in. There's also a hand up from Young Ox, so maybe I'll allow her to talk and
yeah, if you can
go
manage
question
that.
live.
Thanks, Sal.
Come on. Okay, sorry, I'm having internet trouble, but I'm going. Young, we've just given you access to speak if you'd like to ask your question live.
Yeah, my question is for Cass. Can you hear me?
Yeah, sorry, I've just joined in on my phone because the internet here is not very good. So, yeah, I can hear you now.
Yeah, Cass, now I would like to ask you about the dose of basic care, because I had the side effect with Ditropan. So my GP put in a basic care, and she just said 1 tablet a day. I didn't know what's the dose. So it was 10 milligrams. So how often do you take and what dose?
Yeah, so the VisiCare dose is 10 milligrams per day. It can change a little bit, but the main line we go down is 10 milligrams per day. So it's very different to how Ditropan works. Ditropan's very short acting, and so you need to take it more frequently to get the effects. But VisiCare has a bit of a longer span, so that dose once a day is fine.
Does that answer your question, Young?
Oh, sorry, she's on mute. think it does. Trying to say something, but you were muted too.
Kat, what dose when Stephen's dose of Flexicare was bumped up? You went from 10 milligrams to what dose?
Yeah.
He wasn't taking 10 milligrams. He was taking it, I think if I remember correctly, every second day, or like it wasn't a regular, it was something like that. I can't remember 100%, but once we got him on a more regular dose, it worked well.
So 10 milligrams is probably the top limit, you're saying?
Yeah, well, yes. I mean, I'm not sure of other people taking more. Maybe there has. Like, there's a lot of off-label use, but in terms of what we recommend, it's 10 milligrams a day.
And what do you recommend for the Betmega?
So Betmega, you can get in 25 milligram and 50 milligram tablets. We start off at 50. If you look at all the research that's been done with Betmega in terms of neurogenic bladder, 50 milligrams is the starting dose. Some patients or clients are on 100 milligrams. There isn't a huge difference between the 50 and the 100 milligrams in the evidence that we've seen, but I guess obviously if someone gets a little bit of difference, it may help. So generally 50 milligrams is where we start, and possibly go up to 100, but not as often.
There's other questions in regards to things like cranberry or Hiprex and vitamin C, and there some people have asked how they work.
Yeah, I think that's probably timely. So if we probably discuss the topic of UTI prevention and what you can do, because it's not just the UTIs, but it's not sort of the kidney infections as well because of kidney stones. Now, people have probably tried different options over the years, but there's the normal antibiotics and also some low dose antibiotics, they call it. So, well, what's the difference between that, Kath? Now, it seems like low dose medication seems like people take it a lot longer, and it's probably every day for weeks or months on end.
Yeah, so I guess low dose antibiotics is used. I mean, it's a number of people use it. I think if you've had a lot of issues with UTIs, then and you're kind of a bit stuck as to where you go next, sometimes it's recommended for a lower dose antibiotic. So it's essentially that. It's just a lower version of the antibiotic for an extended period of time, and mostly people are on it for months. It's not or years. It's not just if you're treating something different like a prostatitis or something, you'd be on a particular dose, but a higher dose for 6 weeks. There's extended courses of antibiotics, and then there's low dose. So this is just simmering basically in the background to just fight off kind of any bugs that are coming. Look, to be honest, it doesn't happen as often anymore. There's a lot of movement towards antibiotic resistances and trying to make sure that we save up some antibiotics for those infections, but it is definitely a management option that people find incredibly useful. So it's appropriate for some people to be on it. When talking about cranberry, I know we got onto, and there was a question about D-manos and things like that I saw. So there's a whole range of different things that to be honest, there's not heaps of evidence to support any of it, but by all means, most of it is relatively in conjunction with your healthcare provider or whoever's working with you, relatively worth a try. Anything's worth a try if we're trying to look at kind of preventing antibiotic use in conjunction with urinary tract infection. So the D-manos, that works with E. coli infections. I know someone, I can't see it now because I'm on my phone, but I think John Rogerson had recommended it and John Rogerson's a urologist that works at Northeastern Urology, but also with us here at the spinal unit. He's quite well known, I think, amongst a lot of spinal clients. He he would recommend it for, and it's shown some good evidence in working with E. coli infections. So if you're someone who your report says a lot of E. coli, it might be worth D-mannose. Cranberry tablets isn't that great. Be careful of drinking the cranberry juice because it's got a lot of sugar in it. The whole point of cranberry is using the sugar to coat and try and line the bladder wall to stop things. It works on the same principles as D-mannose, but D-mannose is kind of a bit more proven to be effective. Cranberry tends to work in elderly ladies. They've got some good evidence with recurrent UTIs in that population, not so much in spinal. And then Hiprex and vitamin C is something that I think a lot of people take. And Hiprex and vitamin C, again, not a super great amount of evidence. You do need to take it, stop it when you have sulfur antibiotics, so antibiotics with sulfur in it, because they interact with each other. But otherwise, I wouldn't stop. Anything's worth a try. So if you find something that's working for you and you've got a good, if it ain't broke, don't change it, or whatever. What's the saying? I don't know. So I guess with all of those things, there's a myriad of things that you can try to, the true things in terms of bladder prevention infections, it's really going to be dependent on your management too. So depending on if you're reflex emptying or depending on if you're using intermittent catheter or permanent catheters. You know, the true things, drinking water is important. It flushes out your system. But then in saying that, how much water you drink with a suprapubic catheter will be very different to how much water you drink when you're doing intermittent catheters. Those things, you know, we go from doing intermittent catheters and telling people don't drink too much to then getting people with suprapubic catheters and saying drink, 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 drink. So we're kind of doing the opposite, but flushing it through is really important. Suprapubic catheters, I don't know how much you want me to go now, as I could talk forever. Maybe I'll leave it there and then we can talk about the different managements if we need to. We have time after.
Hey, Kath, can I just ask you regarding Hiprex and those other type of things? I always try and work on keeping the pH level in my urine at about 5 or under. Yeah. Can you talk about the benefits of what Hiprex does and other medications around pH in your urine?
Yeah. So Hiprex helps to acidify urine as well as vitamin C, but Hiprex is it's supposed to be an antiseptic. It actually turns into a type of formaldehyde in the urine, but it's safe. But that helps to kind of to clean out any bugs. That's the principle of it. That's why they think whether it works is not super known. But pH. Organisms with a high pH, so, you know, over 5, 6, 7, they tend to, we get the organisms that are stone forming organisms when they come in that high pH level. So, and when you start to get stones, you start to get problems with recurrent infections. The infections go into the stones and you can't get rid of the infection unless you get rid of the stone. So it harbors it in there, creates like this film around it. So by keeping the pH lower, acidifying the urine, it stops, or has those bugs have less chance to really kind of grow. They like high pH environments. So if there is something with high pH, then that's the kind of environment. So by using vitamin C and high dose vitamin C, you know, or the apple cider vinegar, or I think lemon juice was another thing. All we're trying to do is acidify the urine so that we're not creating a nice environment for bugs to grow.
So low pH is acidic, is it?
Yeah.
That's right. Yeah. And in a sense to high sugar or caffeine or those other things, that brings it up higher, doesn't it? Yeah.
Look, it can, but you know, you can't live your life not drinking caffeine or things like that. I'm like, you know, like we're going to be realistic. It's not going to change it that much. There was a study done of, you know, 4 grams of vitamin C, like 4 times a day for months and months and months, and it changed it by 0.01 in the levels. So we've got to put it in perspective. Yes, everything in moderation, but it can, you know, what you drink and what you have can change the pH. But I don't think you should stop doing the things you enjoy to really try, because, you know, I think it would be better if you're having lots of issues to see someone and try and make sure there's no other cause of it, really. There's no other cause of recurrent infections, because a lot of the time there's another cause that we can find.
Can I just say something? It hasn't happened to me for a long time, but sometimes I used to think that I had a UTI, and I'd start taking Alpram, you know, to try to get over it. And it turned out that because just about anything that's wrong with me causes dysreflexia, I don't know exactly what it is until I can pinpoint it. And I thought I had a UTI. I started taking Alpram antibiotics, and it turned out that I was constipated. And once that all cleared up, then I didn't have a problem, and I really didn't need to go on the antibiotics in the first place. I just needed to deal with the constipation. So sometimes if you can't tell exactly what's causing dysreflexia, it may not be a UTI, but yeah, if you're unsure, then it probably doesn't hurt to go on the antibiotics for a short time.
Yeah, I would agree with that. I think your bladder can respond, and bladder is one of the main causes of autonomic dysreflexia, and the bladder can bounce off other parts of your body. So if your bowel's low, it can also push on your bladder. So my big thing is have your bladder in a good condition to begin with. So even if you've got a suprapubic catheter, sometimes it may be worth having anticholinergics or Botox or things like that to make sure your bladder's just nice and happy rather than small and hard and cranky. And if we can make it happier and nicer, then the less chance it's going to set off at autonomic dysreflexia.
Good. Kath, just a couple of questions here. I just wanted to go through before we ran out of time. But someone was asking, they've been taking Ditropan for over 20 years, and they've heard something about it causing dementia long term. Do you know anything about that?
Yeah,
or
yeah.
Is there a safer alternative?
Yeah, so there's been some evidence that's relatively new, where they've talked about there is some kind of possibly an elevated risk of dementia or memory issues with long-term Ditropan use. To be honest, I haven't seen a lot of it myself, but I think now there are lots of options available that if you can, it might be worth trying another medication. So 20 years ago, there wasn't that much out there to use. And so now I think we do have some other things that are available that may be better and more useful, and it could be worth a try.
Excellent. And things like Ural and Hiprex, they're similar products, are they?
Yeah, Ural will alkalize. Ural does the opposite. That'll send your pH up.
So that's the opposite of Hiprex?
Yeah, so now so if you're taking them all together, it's probably going to counteract each other, and you just got to, it's going to complicate things. But Ural will send. Ural is used a lot of the time when people have the sensation of burning. The burning sensation comes a lot from the acidity, and so they try and change the pH so it's not so acidic, so there's less burn. So Ural is probably not one of the things that I tend to recommend an awful lot unless you're avoiding and having issues with burning or things like that.
Okay. And there was another question about an alternative to Hiprex. Is there like an alternative that people can try?
No. Yeah, I guess it's back down to what's causing the problem, and if you've got lots of E. coli bugs, then the D-manos might be worth a shot. There's nothing that creates the same environment or tries to mimic a Hiprex, but no, there's lots of different alternatives in terms of trying to sort out what's causing the issues with the bladder infections.
Okay.
There's a question there as well. What would you consider as frequency or normal amount of UTIs you'd have in, say, 12-month span? Yeah.
So anything over 4 a year, and I want someone to see me.
4 serious ones?
Or me.
4 in a year.
Okay.
That's
4
fine.
really bad ones, because I'm probably one who needs to see you then.
Yeah.
But mine aren't really that bad, I consider.
If you're taking antibiotics 4 times in a year for bladder infections, then you need to come see me.
Yeah, okay. That's what I wanted to point out now. I'm actually, over the years, I've taken antibiotics quite often. So before I find out exactly the best antibiotic to take. Because I was really crook, I'd just take whatever I had at home. And that was a big no-no, big mistake for me, because I've become immune to many antibiotics over the years. Just want to see the experience or the thoughts of other guys there. You know, when you feel like you've got a bad UTI, do you just take whatever you've got around the house just to get rid of the pain?
Or
Or
I just say, Sal, that I know Josh got his finger up, but just exactly to your point, John Rogerson has been making this point for many years. Just get a culture of urine off before you start taking antibiotics, because you're really doing yourself a disservice. And because if you take, it's no point even like half a day or taking the culture after that. And it's because most people have their own pet bug that gives them the UTI. So once you know what bug it is, then you can start becoming more confident with taking antibiotic. But good to get a sample off straight up before you start. So it's a bit hard sometimes when you're sore and stuff, but you can manage with drinking water, taking Panadol and anti-inflammatories, just till you get to your GP, get a culture off, and then start the antibiotic.
Yeah. Look, with myself, tends to, when a UTI hits, it can come on hard and fast. And generally I've got an underlying one that I can deal with most of my normal life. But say if I get run down or get a cold or anything like that, I'll tend to get both things, a UTI and something else, you know. So it's like you say, I do have my pet bugs in my bladder, and my doctor gives me a script for that covers both. But only on really, if it goes too far and I'm getting pretty ill, I'll self-medicate and take those antibiotics, but I'll do a culture first and send it away. And in the meantime, take the antibiotics and see what the results come back like. Yeah.
And just one more useful thing, sorry, Josh, is you can have a script from your doctor ready, or you should also have a specimen jar always at home that's sterile. So you don't have to wait to go to the doctor to get a specimen jar. Take your specimen and then start the antibiotic. Sorry, Josh.
No, you're right. It was pretty much echoing your points there, Mario, because, you know, I was a young male in the country and probably wasn't as educated with UTIs. So I thought one antibiotic would treat all. And like you've mentioned, there's no point unless you know exactly which one it is. And again, for those younger males, it can affect you in many ways. So to be cautious. And, you know, one ways, I also had one, I guess, infection from my UTI that actually recurred down to my testicle, and it blew up massively. So it was called epididymitis. So these things can be serious and it's extremely painful, and I had to go in the hospital. So for all those younger males, keep onto it and make sure you take the right measures.
Yeah.
Some of the older males like Naz as well. Naz.
Also, there's an option. There's an option when you don't have to go into a clinic or a doctor to do a urine sample. You can tick it on the pathology slip for them to come and pick up. Yeah. So if you're crook and need that done, it's an option I use quite often rather than having to go into a clinic. Yeah.
And I was going to add the same thing, that I keep the pathology slips and the sterile specimen jars at home. My GP supplies them to me. I also have scripts for 2 different antibiotics, and I usually alternate those. And within a couple of days, my GP rings me to tell me if I'm on the right antibiotic or not and what the sensitivities are. And I always keep an ear out for the sensitivities, so I try and avoid that antibiotic if I can.
Yeah. So there's a lot to learn in our own individual bladder health, and I really encourage people to look into it more, your own bladder health, and take on the journey with your professionals around you and learn together. Yeah. I really encourage it. Yeah.
I think that's great advice. Anna and Kath, are you happy with that? I mean, what people say, always have a couple of slips and a specimen jar just in case, you know, you do start taking antibiotics, because you need to find out exactly what the UTI is, because not every antibiotic works.
Definitely. I think that's reasonable. It's really important to check what that bug is that's causing it and making sure. Also, taking antibiotics when you really, really need it. So for cloudy or smelly urine, we tend to just not bother doing that. if we can just kind of ignore it or drink some more water. So let's try and avoid that in terms of antibiotics. And if you find that you're getting the same bug with the same sensitivities over and over and over again, you need to come and see us or see a urologist or see someone, because it could be that there's a stone in there, or there's a prostatitis, or there's another reason that's causing you the same infections over and over again. So, yeah.
And if you have, just to add, if you have a catheter in and you've taken a specimen and start on antibiotics, you should always change the catheter at that stage as well, so that you've got a fresh, clean catheter in, and the antibiotics will actually be more effective.
Yeah, and or the gold standard is really taking the specimen from a changed catheter. So if you can change your catheter and take a specimen from them, that gives us a really, really clear picture of what organisms, because a lot of the time on the film of the catheter there is a multitude of organisms, and so we need to figure out which is the one that's actually breaking into that bladder wall that's causing the infection. So if you can get it changed, it's not always possible, I understand that. But yeah, and definitely there's really strong evidence to support that the length of your UTI or your symptoms of UTI will be much shorter if you change that catheter and take antibiotics.
Excellent. That's great advice. Just now, we've run out of time. Just wondering if anyone has got anything pressing to add to that, because the plan is to have a bit of a break. I think Sal's going to organise like a short poll, and then we're going to move on to the number ones, we're going to call it, or number two, the bowel, number 2.
Can I say something quickly, Naz?
Yep.
Just, I saw there was some questions that popped up about blockages and catheters blocking and things like that, and I'm more than happy to people to email me or give me a call, and I can chat about it further with them about some things to do about that too.
No, excellent, because there's a lot of questions I'm sure people would have at the moment, and please don't hold it to yourself. If you want some answers to your question, just get in contact with us. Give us a call or an email. Everyone's got Sal's details, so and ours. Just give us a buzz or an email. Send us an email, and we'll follow it up for you.
We do have a hand from Young Ok, your chance to talk.
My question to Cass, I don't have any problem with my UTI, but the question is, when I go swimming, summertime, I got the suprapubic catheter, can I use a clamp? So I don't need to take this bag. I saw one man, he was using always a clamp, but I've been 5 years with the suprapubic catheter. I'm not sure whether I can do that. That's my question.
Yeah, so that's another tricky question. I knew it was on the list to do. Clamps, yes, you can, but I'm very cautious in saying that. It's very, very important that we know that your bladder is relaxed when it stores urine. If you are using a clamp and you don't have any Betmega or Vesicare or Ditropan or Botox on, and your bladder is really tight, if you're clamping off that outlet, as your bladder stretches, it increases the pressure of your bladder, of what's in your bladder, and it can be high risk for urine to go up those tubes into your kidneys. So yes, I think it's not something that's educated much here at BSCS. I know a lot of units do recommend it. We're probably not as much in that pathway, but it's definitely not a no. But it's just before you do it, or there's just a few things to tick off to make sure you're doing it safely. So I'm more than happy to support anyone through that and just double checking that's okay. But if you're going, and short periods of time are generally okay, but just if you're going to that management for long periods of time, that clamping, you've just got to be a bit careful of.
So folks, we're going to move our discussion over to bowel management. Before